All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. My name is Martin. I'm your host for today, and this morning we have part 3 of a reoccurring series that we call an Invitation to the Inner World, where we discuss a variety of topics on the intersection of psychology, chaplaincy, and medicine. And today we're going to be examining Basic Fault Theory by Michael Balint, and our illustrious guest speaker, returning for the third time, is the Rabbi Yoni Meadows. Yeah, just like the Ohio State University, right? So Yoni is many, many things, but the hat that he's wearing for us today is as an ACPE certified CPE educator and the manager for clinical pastoral education, mission, and spiritual care with Advocate Aurora in the Midwest region. Our format for today is going to be a fairly open discussion. Feel free to unmute anytime or throw something in the chat or use the raise hand function or however you like to communicate. And if you don't want to jump in the middle of our discussion, we'll save some time at the end for questions as well. So with that, Yoni, my friend, the
All
floor is
right.
yours.
Good morning, everybody. Thank you for joining me on a journey into a theory that I'm assuming probably none of you have heard of. It is not famous, somewhat well known in the psychoanalytic world, but that would be pretty much it. But I think it's a theory that has a lot of relevance for today. And I want to begin by telling a story. So the story is you have a psychoanalyst, you have um, a psychiatrist providing psychotherapeutic care, and this is the late 1960s, right around late 1960, 1970. So cognitive behavioral theory and a lot of the modalities of psychology that are um, very common today really weren't around at the time, certainly not on a broad scale. And people were using psychoanalysis um, in various forms to provide general psychotherapy. And I really want to believe that if cognitive behavioral therapy had existed at the time, Dr. Balint would have struggled against that as much as he struggled against a lot of his colleagues in psychoanalysis at the time. So here's the story. So Michael Balint was a very busy psychoanalyst with a practice and saw many patients. And he realized that part of his work was a failure. He realized that he had a whole group of patients that contemporary psychotherapists have looked at his work and have said that a lot of the patients that he was describing that would now be today characterized by personality disorders, things like borderline personality disorder, schizophrenia, and other disorders. What Dr. Balint was encountering were patients who, over the course of their lives, stemming all the way back into childhood, had great difficulty in forming relationships, often had emotions that were intense, but they didn't know how to channel them or to manage them or how to deal with them, had tremendous issues with trust, and really didn't know how to get the help they needed to lead healthier, more stable lives. And the existing usual form of treatment at the time was classic psychoanalysis, Freud, and then followed by object relations theory, which is post-Freudian psychoanalysis, which focused more than Freud did on the development of personality and the ego in the life stages of individuals. The issue, though, Dr. Balint found was that a lot of the care being provided, although rich in interpretation and in meaning, was really pretty much all up here. It was really focused on, well, asking the patient, what are they thinking about? Or, I mean, what are they feeling? But if they have a dream, interpreting the dream, free association of things they're thinking about. It was all very cognitive. And Dr. Balint had a sinking feeling that this really wasn't going to the root of the causes of the difficulties of the patients he was encountering. And then one day, one of his patients said, "Doctor, I feel like there's just something broken inside of me, like a fault line with an earthquake. Something that just doesn't resolve itself. It doesn't heal." And Dr. Balint thought of this and realized these are patients where some traumatic incident or a series of a pattern of care that was not enough to support the healthy emotional development of the patient, combined with often with trauma, has left this patient with what Dr. Balint called a basic fault. This is not a pejorative term. This is not something that the patient did wrong. It's that the patient has never received what they needed. And the ramifications of this he realized, were causing the symptoms of what he was observing, of great difficulties in trusting anyone, great difficulties in modulating emotions, great difficulties in building a healthy sense of self-esteem, and many other very fundamental issues that were getting in the way of his patients living fulfilled, healthy lives. And Dr. Balint's revolutionary approach was that he said, interpreting their dreams and talking to them about the meaning behind what they're thinking about is not going to go to the depths of the emotional pain and the needs that they have. Dr. Balint said, as the problem happened, we need to try to address it with treatment. So if what the patient is lacking, usually stemming from childhood, from the very beginnings of the parental relationship, was trust, love, connection, and feeling supported and seen, the job of the clinician, said Dr. Balint, was, the word he used was reparenting. So let's let that word sink in for a second, as visions of clinical boundaries reverberate through our hearts, minds, and souls. Dr. Balint said we have to be radical and to try to provide a basis of love, connection, and trust that this patient has lacked their whole lives, and to help the patient find the tools within themselves to start building that themselves. Now, I am not suggesting, certainly not as a chaplain, or to anybody on this call, that we throw clinical boundaries out the window. And when we're encountered with patients who have deep-seated emotional needs and a lot of brokenness, again, a lot of what we would probably consider to fit with a lot of diagnoses of personality theories today, I'm not saying we move into these people's houses and take over sole responsibility for their lives. But what I believe this theory does have to say to us here in the 21st century, and I certainly have experienced this richly in my professional life, that so many of the people we encounter, certainly that we try to provide care to, but I would say in general, the healing they need and the issues that they're struggling with are often stemming from very deep wounds within their hearts, minds, and souls. And suggesting practical behavior modification or practical solutions to individual problems might have some value, but is not going to go to the depth of what they need and what's causing their distress at core. And I think as a chaplain, I have to say there is a deep amount of truth that I've experienced in that statement. This is the heart of what I wanted to talk about this morning. And again, Dr. Balint is not a household name, but his theory, I think, reverberates through the years. And after our society coming through the pandemic and seeing the epidemic of mental health needs get turbocharged by COVID, which I experienced as a on the floor as chaplain in the ICUs during COVID, the problems that we're facing as a society are very deep and really go to the heart of connection. Let me see Thomas's question in the chat. Oh, okay. Thomas, a thought: seems like smart devices have resulted in several generations having difficulty forming relationships. Yes. And to experience emotions in what appears to be a form of isolation from reality and nature. At the same time, there is a false parenting or information across the web. Can this be considered a fault in an unprecedented level? That is a great question. Then he has some other questions. Let's deal with that one first. I think it is almost beyond debate, and it's certainly been my experience as a clinician and as a parent, that in the last 20 years, the pace of life, the ubiquitousness of social media have resulted in generational shifts of how people receive and process information. My youngest, who's 16, we talk about music a lot. She has said to me many times, the idea of a song being more than 5 minutes to her is anathema. Why would you listen to something that long? That's not what a song should be. So when we create additional challenges to connection, to be able to connect to each other as human beings on a personal, emotional, spiritual, psychological level, and we substitute for that mass information, the two are not the same. It's not my brilliant insight that someone else said it. We know more than ever before, and we are less wise than ever before. We know trivia, we know facts more than ever before, but we understand less and less. A question: does the subconscious exist, or is it a construct for us to process psychiatry medical aspects? I firmly believe the subconscious exists. That's my training. I work, the basis of my theories is psychodynamic psychology, depth psychology, which presupposes the subconscious. I would simply say that I think it's helpful to think of human beings like icebergs. What you see 10% of the iceberg, the rest is hidden beneath the water. And when we think of how we make decisions, how we decide what's important, how we assess the world around us or ourselves, so much of that is based on emotions, associations, what in classical psychoanalysis we call transference, um, connections that we may or may not realize. American culture teaches us to think that everything is rational and cost benefit, but um, so much of how we see the world is based on something far deeper to who we are than that. And then finally, from Thomas, you're just moving the cursor over. A question, my understanding of psychoanalysis to bring a person back to normal. I'm wondering what is normal, or what would good parenting look like? Excellent question. Um, all of this, of course, is very culturally determined. I would say, how do we find ways for people to, in terms of normal, I want to look at healthy. And how do we find ways to help people feel connected to others, to feel seen, to feel valued, to feel cared for? When we look at the indices for trauma-informed care, which this forum will be looking at for palliative care next week, those are some of the fundamental things we look at in terms of the impact of trauma on individuals. Do people feel connected? Do they feel seen, heard, valued, loved? Do they feel that they're part of something and that they have agency, that they have the ability to order their lives at whatever developmental stage that makes sense? So this is a lot, and it's a lot of deep thoughts and a lot of processing. Does anybody else have any questions to further get into what I think is some fairly basic questions of what does it mean for us as clinicians to try to help, to try to treat other people?
Well, Jerry, please.
Well, I think, Yoni, first of all, thank you. And I'm probably one of the few that is aware of this. And so you're preaching to the choir with me. So
Wonderful.
but you said it, so I don't really need to ask the question. Given that I believe wholeheartedly, philosophically, that we got to look at things differently. And it sounds like you were going to talk about that. How do we, in our crazy lives and our work, how do we even begin to scratch the surface and do this?
It's often been said, thank you, Jerry. It's often been said that when I was going through chaplaincy training, one of the first things that I was taught was one of the greatest gifts that chaplains can bring to a situation is, whenever possible, to slow things down. Because so often, certainly in medicine, things happen very quickly and we react. And so basic to providing good care is good assessment. And good assessment can only happen if there's good connection, because you can't assess what you don't know, and you don't know if you're not connected to it. So I think that if we're looking to trying to change the world and to help those that we have the privilege to care for, we first have to begin with trying to connect to and know the entire person that we're speaking to. I often tell the story. I'm an Orthodox Jew, and I often tell the story of the first Palestinian patient I had as a chaplain. And it was a profound encounter. It was a very positive encounter. And it was a profound encounter, really, first and foremost, without telling the whole story, but really first and foremost, because both of us instinctually made the decision in the moment to see each other as full-fledged human beings, and not as what I'll call cardboard cutouts of, his tribe and my tribe. We spoke to each other by name, and we saw each other, and it worked. So that's where we have to begin. so delighted that you're familiar with the theory.
Yoni, can you talk a little bit, maybe pragmatically, about how we can explore some of these topics with patients, whether you're a chaplain or a physician or a nurse or anybody else in the healthcare team?
Sure. So I think I know the stresses that nurses and physicians are under time wise. When I hear nurses talk about how they don't have time to eat, they don't have time to go to the bathroom and eat. And I hear physicians talking about if I don't see, a given number of patients in a day, trust that I will hear about it. I understand the challenges that are in our path. I think one really good, deceptively simple place to start is to always have a rich clinical curiosity. So when we encounter I'm speaking about patients, but I mean really applies to anybody, but I'll speak about patients. When we encounter a patient, certainly for the first time, but really any time, is there anything about the patient that seems to pop out? Do we notice something that's incongruent? Do we notice something different if we know the person? Do we notice something different about the person than how we knew them before? Are they telling us that they're doing fine while their face looks like they're in a lot of pain? Anything that we notice that becomes something we can investigate and use as a pathway to connection. And I think to always be aware of how we're feeling in the moment as clinicians, what is our experience of the moment, and to always remember the difference between sympathy and empathy. Sympathy is a detached recognition of what we perceive as the emotions of somebody else. Empathy is when we're trying to connect what we're feeling and the other person is feeling, and we're trying to authentically be with them in the moment. Empathy is going to create a far different therapeutic bond than sympathy will. I think that there's a lot of value in medicine and in science. We're often taught that we're always looking for what is new and the new discovery, the new development. I was taught in my spiritual tradition and my chaplaincy training that oftentimes what is most deeply true about us as human beings has not changed a whole lot in thousands of years. So the purpose of our training and the work that we do is not necessarily to find what is new, but is to point out what we already know deep inside of us, and then to explore what does that knowledge, what is that within us, and how does that shape us as people and shape what we're going to do. I firmly believe that virtually all of us have what we need inside of ourselves to develop our potential and to live the lives that we have the potential to live and I think are destined to live. But that only comes with understanding who we are and engaging those strengths and those challenges. It's not about the new shiny thing. That is definitely not how I roll. Eve Conversa, extraordinary talk, much appreciated. Thank you, Eve.
I agree. And if I could take the liberty of asking you another question that's obviously don't have the knowledge of you. My understanding over the years of basic fault, and then I've been kind of reading some stuff on existential therapy, is the concept of basic fault and the concept in existential therapy of existential guilt, are those I mean, are those two different from your minds, Yoni, and this is kind of a academic question, I guess, but
It's a great academic question. I'm not familiar enough with Yellum's thought to answer the existential question. I know his group theory very, very well, but I don't know that aspect of his thought. I suspect they are very similar. Really what it gets to is, do we have the courage to go into the heart of who we are, our what was called in Hebrew our etzimus, our essence, the deepest aspects of what makes us who we are as human beings? Do we have the courage to go into that within ourselves? Because we have to do that first as clinicians. And then do we have the courage to go there with the people we're providing care to? That I think is the fundamental question. That was the famous statement of Carl Jung, which I think is an absolute clinical truth, that he said the proportion to which we are able to enter into the inner worlds of those to whom we provide care is directly proportional to the degree to which the clinician is able and willing to go to within themselves.
And again, I agree completely with that statement. And at the same time, as we've talked about, and I'm not trying to be negative or argue for limitations, that's terrifying, because I believe that in the real world we have, it seems like it's so hard to do that. But thank you.
You're very welcome. Well, I think we try to do it on whatever level we can.
And I agree with you, Yoni. As clinicians, we approach the patients, and sometimes we have to recognize our triggers, because they may remind us of a family member or someone within our lives that has a negative impact, and recognizing that is important, because it's hard to develop a clinical relationship with someone who is bringing up these feelings and these thoughts, and that's really sometimes hard, and sometimes it's hard for us to acknowledge, because we're here to help, but sometimes we're not able to help everybody. And
oh yes,
and we're coming out together as a team, or privately, kind of addressing those issues. And yes, there isn't going to be any, I think, a new exciting theory. I agree with you. This has been around for centuries, and if we're just trying to connect with people, because people, a lot of patients, yesterday I saw a couple patients who just feel so disconnected, and they want to connect with us because we're trying to connect with them. So it really kind of coincides very deeply of what you've all said today, Yoni, and it's just great insight for us to recognize as clinicians that to connect with our patients. Times it takes a couple of visits.
Absolutely. Yeah, absolutely, Jen. Thank you. And I do want to state our current Surgeon General, Dr. Murthy, has declared isolation as a national health crisis, which goes to the heart of everything we've been talking about today. And he's absolutely right. And COVID made it much worse. It was already very bad, and COVID fed it Miracle-Gro. And it is a huge, huge problem in society. And so I do want to say also quickly that one very interesting thing that I've been learning from other clinicians is how to pick and choose, like in addictions, cognitive behavioral therapy is often the right way to go in the beginning, because if the person, for example, if the person is a heroin addict and they keep doing that, they might die. It's important for them to stop doing heroin, and CBT often is the best way to address that in the moment. The why did they start doing heroin in the first place is a psychodynamic question. What need was the heroin filling? Because if you don't address that, then you might stop the heroin, but they're going to find something else to be addicted to. So knowing which modality can be most useful in any given time. Caitlin had one more question. I don't know if we have time.
No,
Great.
yeah, perfect.
So Caitlin, my colleague, Caitlin Kim, Yoni, what you're sharing is connecting some work I'm doing with our teams at Sinai related to nonviolent communication. Fantastic. Can you speak to the role of how we communicate in fostering that deep human connection you referenced in your story about the Palestinian patient? Wow. There is a world in that question. So I would say that to give a brief answer to that question, to begin with empathy rather than sympathy whenever we can, to make the decision, and it is a decision, that we're going to invest in this encounter. We authentically care about this other person. A very key part of anti-suicide training, which I've taught, is to communicate to the person that you were trying to prevent from attempting suicide, is to communicate to them that you authentically care whether they live or die, and to then help them get help. But it begins with whether or not you're alive or not makes a real difference to me. So I think that, and it doesn't have to be necessarily, it's often not going to be the words we say necessarily. It has to be use of self. You know, that term from social work and chaplaincy and psychology. How do we use how we feel, how we, what we associate with what's going on in the encounter? How do we use that without using our own story? How do we put that into our response? It has to begin with the search for empathy and a deep human caring. If we begin there, that is going to foster human connection, because as human beings, we instinctively respond to that.
Thank you, Yoni. We appreciate it. Do you want to send us out with any last piece of wisdom or advice?
I think I want to send us all out with sort of the opposite of that. An acknowledgement of all of our deep humanity. An acknowledgement that none of us are perfect. We are all beautifully flawed. And we are all a volatile and beautiful mix of what we're proud of and what we struggle with. And if we're able to acknowledge all of that within ourselves and utilize all of that to be who we are, then we can help others to do it. And that is profoundly healing. So let's begin by being able to acknowledge within ourselves that we are who we are for a reason. And who we are is probably pretty darn good.
Beautiful. Thank you so much.
Thank you.
All right, everybody. Have a lovely weekend.